Everyone, this video is going to start a new series of ours focusing on the diagnosis and management of postoperative complications. And as you'll probably see from the name here, talking about hypoxia as opposed to some sort of specific complication like a PE or pneumonia, we're trying to really present these complications the way they would show up in the actual hospital. And so what med students or what medical school really prepares us well for is getting all the data at once and then answering a UWorld question correctly to do a diagnosis. And unfortunately, in the real world, you're operating on limited data, right? You don't get a page that says, "Doctor, your patient has pneumonia. What do you want to do?" You get a page, "Your patient is hypoxic. What do you want to do?" And so how do we systematically move from this kind of gray unknown area where we still need to do something because the patient is hypoxic and we can't just let their brain be starved of oxygen for a prolonged period of time. But on the other hand, we don't actually have a definitive diagnosis to give definitive treatment for. So how do we temporize this acute issue and then systematically work towards a diagnosis while keeping the patient safe? So an example page here, maybe your patient's been fine post-op up until this point, and all of a sudden they're requiring 6 liters of nasal cannula. And so, like I said, the med school way to think about this is, oh, what's the differential? I have to know the differential before I act. But that's actually usually not how the art and science of medicine works in real practice. So when I get this page, actually differential is moved down here towards the bottom. Actually, the first thing I'm thinking about, especially in something really acute like hypoxia here, or maybe something like hypotension, is we've got to think about the immediate treatment. And if they're not oxygenating well enough on their current treatment, we're going to have to bump that up despite not knowing the underlying diagnosis because this is just such an acute issue. While I'm thinking about what treatment the patient needs, I'm also thinking about that basic workup. And if something's acute, I don't want that workup to take forever. So usually while I'm walking up to see this patient, I'm going to put a few things in the EMR that I know I'm going to want every time. And that way the labs can get drawn, the techs with maybe the chest x-ray can get up to the floor and take that image, right? I want those things to be in motion before I even start walking up to see the patient. Finally, and usually related to your treatment, is the level of care. And we're going to talk about that spectrum, but all places in the hospital are not equal, and whether we're talking about the general care floor or the ICU, different treatments are available in different places and different patient clinical scenarios. Depending on their stability, they belong in different places of the hospital. So that's what we're thinking about when it comes to the level of care. And then finally, once all of these things are settled, we can really go back to that differential. Usually by this time, some of our workup's coming back, and we can start putting the pieces together and thinking really hard about what the differential is, and that will lead us to our definitive therapy. But like I've said before, we can't wait for definitive therapy. We don't have all the time in the world, especially in some of these really acute issues. So going on to treatments. First, before I talk about these, I want to just briefly review respiratory failure. So as you should recall from, I don't know, your palm lectures or something like that, there's 2 modes of respiration, or 2 kind of main functions. There's oxygenation and there's ventilation. So oxygenation obviously deals with oxygen, ventilation deals with the clearance of carbon dioxide. And so you know from the page that your patient's having an issue with oxygenation. But what you don't know is if they're having a trouble with ventilation. So that's going to be part of what we're thinking about with our treatment as well. So that'll come up later. So now going to our treatments, this is ordered like everything I think about. There's a spectrum. So there's least intensive oxygen therapy at the top and most intensive at the bottom. So nasal cannula, that's just a nasal prong, goes in the nose, delivers relatively little amount of oxygen. Sometimes you want to step that up. Maybe they're a mouth breather. An oxymask is essentially the same thing, but the oxygen is delivered through a plastic mask that covers the mouth and nose instead of just going into the nose. And then after that, we start to think about types of oxygenation support that provide positive pressure. So you see specifically down here, this PPV stands for positive pressure ventilation. That's CPAP and BiPAP. Those are typically full face masks that go over the mouth and nose, and CPAP provides a continuous positive pressure, or PEEP, P-E-E-P, positive end expiratory pressure, whereas the BiPAP, Bi-4-2, provides 2 levels, 1 level for inspiration and 1 level for expiration. If we think back to that oxygen For CO2 spectrum we were talking about, the CPAP is good for oxygenation, while the BiPAP gives oxygenation in addition to CO2 clearance. And then right here in the middle, I didn't talk about this one first because it's a bit of a hybrid. So high flow nasal cannula, it's getting a little messy. Nasal cannula is just like nasal cannula up here. It's two prongs that go in the nose, but this one is supercharged. It's got the HF, which stands for high flow. And so you can give a lot more flow. You can get more oxygenation support than with just normal nasal cannula or oxymask. And you can get a little bit of that positive end expiratory pressure. Depending on who you ask, you'll get different numbers, maybe around PEEP of 5. Obviously, below high flow, we talked about the positive pressure ventilation options already. And then finally, worst case scenario, all these things are not working and you're thinking about calling anesthesia for an emergency intubation of your patient. So pretty simple, pretty straightforward, but I find it's really good to just have this reviewed in your head. And so if in the heat of the moment, the room's stressed, the patient's desatting, people are looking at you, what do you want to do, doc? And you don't freeze, you can just think very logically, okay, well, they're failing nasal cannula or oxymask. Maybe it's time to call respiratory and step them up to high flow. Maybe they're on high flow, it's time to step up to BiPAP. And if they're really struggling on that BiPAP and just not doing well, you don't have to think about it. You don't have to, freeze or give it a ton of thought. If they're failing, your next step is going to be intubation, and you can start putting the pieces in place for the right thing to happen without too much delay. All right, and now thinking about the workup. So this, like I said, I actually like to order even before I go up to see the patient. If I have a patient that I'm really worried about their respiratory status, I always know I'm going to want a chest x-ray, and it takes time for the techs to get my order and get up there with the machine. So I always want that in before I go up to see the patient. And I'm usually ordering a VBG. Once again, thinking about those two modes of respiration, the VBG is going to tell you about their ventilatory status. So if I have somebody who's hypoxic and they're hypercarbic, their CO2 is really high, then I'm definitely going to be choosing something like BiPAP as opposed to CPAP if they're requiring that level of support. All right, and then moving on to level of care. Once again, we have the spectrum of care. So least intensive care, kind of general care, that's probably what you typically think of when you think of a hospital, down here to the most intense, being the intensive care unit or the ICU. Most hospitals have a level of care in between that. Many places it's called the intermediate care or IMC, but your place might have different names for those specific units. Obviously, people on general care, they can be on room air, they can be on things like nasal cannula, oxymask, and then depending on your institution, usually when you start thinking about the more positive pressure strategies, high flow, CPAP, BiPAP, things like that aren't just for, he wears the CPAP at night type thing, but for an acute treatment of hypoxia, the patients are probably going to need to be in a higher level of care, either the IMC or the ICU for something like that. And of course, intubated patients are almost always stepped all the way up into the ICU. And once again, this isn't supposed to tell you all about these details. Just know that there's these multiple levels of care, get a sense of what they are at your hospital, and then make sure you're thinking about that spectrum as well when you're talking about the acutely ill post-op patient. All right, and now finally, we can start thinking again about our differential. So what's nice is we've dealt with all of these acute issues. We've started our initial treatment. We've worked on getting our initial workup. So these things, now that they've been sent off, usually will start coming back. Our chest x-ray, our VBG, maybe some other labs if I thought they were warranted at this time. And our patient is at the appropriate level of care that they need. And now we can go back and think about our differential. Hopefully your patient, when you went and saw them, was alert and oriented enough to talk to you. So you are also thinking about the elements of your H&P. That will give you a ton of info as to what might be going on. And really, going to the differential itself is not the point of this video. There's way too many things to cover. We can't give you the amount of details about all of them. A short list might be things like atelectasis, pulmonary edema, pneumonia, bronchospasm, PE, pneumothorax, opioid overdose. I mean, the list goes on and on and on. And that's really where you apply that med school knowledge to the clinical situation in front of you. But what we've done to get us to this point has kept the room calm, kept the patient safe, and really allowed you to now put your full attention towards figuring out this difficult problem rather than being stressed about, oh my gosh, what should I do? The patient's desatting, a million things going through your head. And then once you have your differential in mind, now you can get that specific treatment, maybe antibiotics, maybe anticoagulation, depending on what the underlying cause is. But once again, this is usually the last step. And if something acutely goes wrong with your patient, they get really hypoxic, there's a severe issue that needs your attention right away, you're very rarely going to have a final, I should probably say diagnosis, to work with. So hopefully this video helps you get there, at least for post-op hypoxia. This is not intended for clinical purposes. This is for education only. Do not use this to diagnose or treat any diseases. And we will see you next time.